Hi, welcome to this week's episode of Ask Dr. Jessica. This week, we are going to talk to a pediatric dermatologist, Dr. Nicole Harter. She is the Chief of Pediatric Dermatology of Children's Hospital in Omaha. Hi, Dr. Harter, how are you?
Hello, good. Thank you so much for having me. I'm so excited to be here.
Thank you so much for joining me. There's so many pediatric dermatology questions that come up. What a treat for me to have you to ask questions to.
Well, I can't wait. They are incredibly, incredibly common, whether concerning or not concerning, but I will hopefully help alleviate when to worry and when not to.
Thank you so much. Yeah, I remember when I was trained to be a pediatrician, someone told me that 20% of all general pediatric visits have to do with the skin. So
It's
definitely a
amazing how
common.
much skin disease you see as a pediatrician, but you don't get a lot of education on it because none of us get a lot of education on it in medical training unless you decide to become a dermatologist.
That's so interesting. It's true. Actually, thinking about that, that's a very true statement.
Mm.
Okay, so tell me a little bit about yourself. Who are you, and how did you decide to become a pediatric dermatologist?
So I was always interested in medicine, knew I wanted to go to medical school, thought I'd be a pediatrician, got into medical school, realized I really liked procedural focused things, so I wanted to do something pediatric procedural based. And then I had a friend tell me, why don't you do a dermatology elective? I thought she was crazy. The one thing I realized I didn't want to do my first day of medical school was I would never be a dermatologist, never. But I didn't know anything about it truly. And so I did this 2 week elective with a new pediatric dermatologist on faculty at my medical school, and it blew my mind. She could see kids, she could see adults, she could do procedures. It was super nerdy, lots of pharmacology and research and literature, and everyone was super passionate about what they were doing, and they all seemed pretty happy doing it. And I didn't even know it was a thing. And so from there on, I just knew it was peds derm. So I did a dermatology residency and then a pediatric dermatology fellowship where I focused on just treating more complex pediatric medical dermatology. And then I was on faculty at the Children's Hospital Los Angeles for the past several years before coming out here to Omaha to start a new peds derm division. So I think I get the best of all worlds of dermatology because I get to do all pieces of it, the medical stuff, the common stuff, the complex stuff, the surgeries, but it's all in kids, which is so much more fun.
So you get a little bit of everything, it sounds
Yes.
like. Now, how many true pediatric dermatologists are there? Do you have an idea of how many there are? I know there's not that many.
In the world, probably around 450.
Wow, that is not
Yeah.
that many.
No, it's not that many. We're kind of hard to come by.
I mean, I hate to bring up finances, but I know what I hear a lot is that because general dermatologists can make a good living, and then when you become a pediatric dermatologist, it's another couple of years of training, and then you end up generally making less. So I hear that there's not a lot of incentive to become a pediatric dermatologist.
No, I'm glad you
Um,
bring it up because it's so true. In general dermatology, you do a lot of procedures because you're doing a lot of biopsies, and then also maybe more cosmetic procedures if that's part of your practice. And then in pediatric dermatology, you do extra training, and then your reimbursement is generally significantly less because you're not as heavy on the procedural side because thankfully kids don't need as many biopsies, and of course we're not doing cosmetic procedures on children.
no Botox for kids.
No, no, we're
General,
not. We're not
or
into
cosmetic Botox. No. Yeah.
that.
Well, that's great. I mean, I think that says a lot about you. Just that you have the passion to be a pediatric dermatologist and that you continue the training to help kids. So thank you.
Well, thank you. And I think it's a community, as pediatric dermatologists, it's a community of really awesome people. So if you find a board certified pediatric dermatologist, they're probably a pretty cool person and you're probably in pretty good hands.
All right. So I thought I would get into, while I have you, asking some general common questions that come up in my office. The first one being eczema. Eczema is something that I see so much of it, and I know a lot of people listening have probably dealt with some eczema. So I thought we'd start with atopic dermatitis or eczema. Maybe in generally speaking, do you know how common it is, or what are we talking about in terms of prevalence with kids? How common is eczema?
So it's incredibly, incredibly common. So as you said, atopic dermatitis or eczema, as it's frequently called, affects between 17 and 20% of all children, which is an astounding amount. So think about your child's maybe second grade classroom. There's probably at least 5 children that are clinically diagnosed with atopic dermatitis, but probably several others that have dry, sensitive skin that maybe were never truly given a diagnosis of it. So incredibly, incredibly common and can be very distressing and life altering at times.
And when should parents be on the lookout for it, or should they be? What kind of symptoms will they notice on their children's skin to clue them into a diagnosis of eczema?
So, kind of preemptively, and just thinking about their own personal history of allergic disease, what we call atopic disease, if the mother or father have a history of seasonal allergies, say hay fever or allergic rhinitis, atopic dermatitis, or asthma, if they have any one of those things that run in their family, their child is predisposed to developing one of those conditions. And then when a child, with or without that history, starts to develop red, kind of dry, scaly areas on the body that seem to maybe come and go in different random places. That's one thing to really clue you in that maybe there's something else going on here versus just dry skin. Dry skin is usually, that's it. It's just dry. It may look a certain way and maybe is occasionally itchy, but it's not usually red and really rough and textured like sandpaper. And then when your child is scratching a lot, that's the biggest thing families usually notice is, oh my gosh, this is uncomfortable for them. That's really when to think, okay, maybe there's something else going on here.
And when you talked about locations, are there any locations that we can think about?
Yeah, so to think about it based on the age of the child. So in a little baby, say under 2 years of age, but more commonly in infancy, we get a lot of eczema on the cheeks, and that can be related to a lot of drooling and just irritation, especially from feeding, that can trigger an eczema flare on the cheeks. Then you get on the upper outer arms and sometimes on the outer thighs. I can't see my thighs, but my outer thighs. As you transition to an older child, say between 2 and 5 years of age, up to early adolescence, it starts to happen in more classic flexural areas of the body. So the folds of the creases of the arm, creases of the back of the knee, and it can also happen on the neck areas. As children get even older and into adulthood, it's more common to have localized areas of eczema, which may include hand eczema or hand dermatitis, or maybe more of a facial dermatitis. So it does depend on the age of the child that we're looking at on where the eczema is going to be most pronounced.
Now, in terms of diagnosis, do you ever see somebody get diagnosed with eczema in adulthood, or is it really something that we notice typically starting from childhood? Like, do you ever get a surprise diagnosis later?
You can, especially when there's hormones at play. So some women after pregnancy will develop a new diagnosis of eczema that they never had. And certain adults can be diagnosed with a new diagnosis of eczema, but it's uncommon or less common. And it makes us think of other things that could be at play. Is there a contact allergy, meaning that is their skin coming into contact with a substance that's actually causing a true allergic reaction? It's much more frequent that they'll say, oh yeah, I had some dry, sensitive skin when I was a kid, but never anything quite like this. And they're expressing that they have significant rashes of eczema as an adult. Usually there's some sort of history that there was skin sensitivity earlier in childhood.
So would you say the most common presentation would be as a baby, or what age should parents kind of think about this?
I would say most frequently between 6 months and 2 years of age is the first initial onset of atopic dermatitis. And then it does tend to improve over time. I do have families that come in and they have read or been told that at 2 years old, the skin's magically going to change and eczema is going to be done. And I wish that was the case. Unfortunately, it tends to be a gradual, slow process of improvement. And it depends on how severe the initial presentation is. If a 6-month-old baby is having very mild little scaly patches, I can usually counsel the family that, over time, they may have to use some medicated creams or ointments here and there and be careful about their skincare products, but they're never going to have severe eczema. If I have a 2-year-old with severe eczema, I'm usually telling the family, you know what? Their skincare regimen is probably going to be part of their day-to-day for most of their life, and they're going to always have to think about it. It doesn't mean it has to be bad. We can help take excellent care of it and control it, but it's going to be a more substantial component of their life. So there's no on and off switch regarding age for atopic dermatitis, unfortunately.
I think that's an excellent point, because a lot of parents will see their child's skin clear up, like they'll treat it well and they'll do what they're supposed to do. It'll get better. And then I think it's disappointing when it comes back, but that's the normal expected course, correct?
Yes, it is a chronic inflammatory skin disease. And when we think about chronic disease, you say that word and people think, oh my goodness, it sounds like like high blood pressure or diabetes, something really, really scary. Chronic just means we don't have a cure for it, unfortunately, and we can control it really, really effectively. But their skin will go through flare ups and calm downs and flare ups and calm downs. And I routinely tell families we will work to get the skin under control, and then you'll be doing everything right, and skin will be perfect. And then it'll flare up, and we don't know why. And sometimes we know triggers. Things that can flare eczema are when your child gets a viral illness, a cough, cold, runny nose. If they get a vaccination, it can trigger their immune system like we want it to, but also stimulate an eczema flare. Sudden changes in weather can do it. A rough, scratchy, wool-based fabric can do it. And then sometimes we just have no idea because eczema has a mind of its own.
These are some excellent points. I never thought about the vaccine, but that's a good
Yep.
point.
Occasionally. And sometimes it'll seem like, oh, they went in for their 6-month vaccines and 2 weeks later they're getting this horrible rash. Well, the rash was actually just eczema. The vaccines did not cause it. It was just one of their first big immune stimuluses to kind of bring the eczema out.
Interesting. Okay, this is great. So let's say a parent does notice first signs of eczema in their child. What are some advice, like some typical general advice that you offer parents?
Yeah, so dry skincare recommendations. What are the right ones? There's so much out there about how to take care of newborn and infant skin.
And there's
So
so
what
many
I
products on the market, so
so
many.
many products on the market. Oh my goodness. And we'll get into a little bit more product discussion because there's many that are marketed toward children that really should not be used on children or anyone. So
Right.
for people with sensitive skin, atopic dermatitis, I recommend more frequent bathing. And that may sound counterintuitive, but let me explain why. So we have to do the bathing in the right way, meaning that you have a short daily bath or shower, 5-10 minutes, lukewarm water, just getting water on the skin to help moisturize it and cleanse it, but not using truly any soap at all. This is in young kids. They are not sweaty teenagers. They don't need soap. Even the sensitive skin soaps that are marketed for children with eczema, at some component can dry you out a little bit. So no soap at all, no loofah, no scrub brush, no washcloth, no sponge, nothing like that. Just some warm water. As soon as they get out of that bath or shower, a gentle pat dry with no harsh rubbing with a towel, leaving a little bit of that water on the skin, and then sealing it in. We call this the soak and smear. So they soak in the bath, and then we smear them with the thickest, greasiest emollient we can. My favorite things are going to be Vaseline, Aquaphor, CeraVe healing ointment. The thicker, the better. Now, some older children really do not like the sensation of Vaseline or Aquaphor on their skin. It's too greasy. So I'll usually try and kind of bargain with the child and the family and ask that maybe we can put on Vaseline before bed. So they put on jammies, they go to sleep, it doesn't bother them. And in the morning, they can use a cream-based moisturizer. It's really important when you're looking at the products you're purchasing that you're noting whether it says lotion, gel, solution, cream, or ointment. There's different components and they actively work in different ways on the skin. A cream has to have water in it to thin it out, so it has to have preservatives. When you put a cream with water and preservatives in on irritated skin, it can really burn or sting. And sometimes that sets you up for a really bad negative feedback loop where you're putting a cream that's marketed for sensitive skin on your child's eczema, it burns them, and then they don't ever want to put on moisturizer again. So if you're really flared up, Vaseline or Aquaphor is the way to go. And for more maintenance, you can use a thick moisturizing cream. We don't, in dermatology, we don't delve into that lotion world. That's it. It's like a 6-letter word. We don't talk about lotion in dermatology.
And what about Vanaply?
Oh, love
That's a very
Vanity.
good,
So that's
okay.
Vanity Cream's answer to Vaseline or Aquaphor. The Vanity
Okay.
Cream line was designed for children that actually have skin allergies and sensitivities and truly diagnosed allergic contact dermatitis to a lot of the fragrances, preservatives that come in many over-the-counter products. So the Vanity Cream line is excellent for sensitive skin. Vanity Ply is their ointment-based moisturizer. Vanity Cream is their cream-based moisturizer, and it is a wonderful product. They make a line of sun care products as well as sunscreens that are mineral-based, and they make shampoos and bar soaps as well.
And they're, lanolin free. I like
Yes, they're
the
free of truly
fragrances.
everything.
Yes. Okay, so what about patients that a lot of patients want to use, quote unquote, natural products? They want to use coconut oil. Do you find success with olive oil, coconut oil, uh,
So
products of that nature?
you really have to be careful with what type of natural product you're using. One thing that I'm all about using, whether it be complementary and alternative medicine and whatever family's preferences are. However, think about this. Poison ivy is a natural product.
Yes.
It doesn't cause good things on the skin, right?
No,
So
I would
just because it's
agree.
natural doesn't mean it's good. No, it really doesn't. The evidence shows that coconut oil, straight pure coconut oil, the kind you buy at, Trader Joe's or Whole Foods that's meant for cooking, is anti-inflammatory for the skin. So if that's a moisturizer that the patient and family want to use, I am all for it. I like that, especially for scalp dermatitis because it's easy to kind of drip in those areas.
Hmm.
However, things like olive oil, sunflower oil, safflower oil are actually pro-inflammatory, increase inflammation in the skin. This can make things worse. So we want to avoid those oils. Things like essential oils, lavender, peppermint, calendula, eucalyptus. If the patient tolerates that oil, it doesn't seem to make their skin worse, I'm okay with it. However, these can all sensitize patient's skin and they can develop a true allergic reaction to those oils. So it does worry me that we may be having an eczema component, but we're making it worse by actually causing them to have a skin allergy on top of it. So in someone with eczema that's harder to control or more severe, I usually have the family eliminate any variable and we go back to true basics, things like Vaseline Aquaphor, Vanity Vanity Cream, and nothing else. And then as skin's under control, if they want to slowly reintroduce products one at a time to see if there's maybe a certain natural fragrance they really like to have in a humidifier or as part of their skincare regimen, they can try it out and see. But if it doesn't go well, we have to take it right back out.
That's great advice. Thank you. And what about, so let's say you do the Vaniply, Vaseline, Aquaphor, and you see some improvement, but not a ton of improvement. What would the next step of advice be?
So you really do
Sort of
need
a
to,
leading question here, but
the next step of treatment is going to be using a topical corticosteroid or a cortisone ointment or cream. And I know a lot of families get very fearful about putting a topical steroid on their young child or infant. It's really important to understand that when you're doing this with a medical professional, we're prescribing you the right concentration of ointment or cream and telling you where to apply it and how to apply it, and we're doing it safely together. If all we do is put, say, over the counter products, for example, Vaseline, on really irritated eczema and it's not improving, it will continue to smolder and smolder and smolder until that fire builds and builds and builds. It gets worse and worse and worse. The child is scratching. They create open areas of skin, which can allow for bacteria to get in and then cause an infection, which can make the eczema worse and also require the need for either topical or oral antibiotics. So it's a huge compounded picture. The earlier we control it, the less steroid we need in a smaller concentration. But it really is important that if it's not cutting it with over-the-counter creams and ointments, you need to see your pediatrician or pediatric dermatologist to get on a topical steroid skincare regimen.
and I think you bring a great point. When I talk to families where the skin does require some or would benefit from over-the-counter or prescription strength steroid, I think when I say the word steroid, a lot of parents get taken aback. They are nervous to give their children steroids. And I once talked to, I heard a dermatologist give a lecture where they said, we really wish that they didn't call it steroids. Like we wish we called it something else because, they're really safe for kids, as you mentioned, in the right concentration, strength, and, benefits the child so their eczema does improve. Would you agree that when you see kids use proper use of steroids that the side effects are minimal? Or can you comment on what the side effects might be?
Yes, absolutely. So I think when people often hear steroids, they think of either medicine we're giving by mouth or
Right.
medicine that can alter hormones within the body, which is
Like a
not what we're doing.
bodybuilder?
Yeah, different class of steroids entirely. And we're talking
Right.
about creams and ointments. They are only absorbed inside the body if we're putting it on the whole child for far too long. I'm talking months at a time in concentrations that are too strong. So what I tell families is that I will give you the appropriate strength to calm down this skin rash. And then after we calm it down, we'll work on a tapering plan where we're not using the steroid as frequently. And then we'll work on decreasing the concentration until you're only using this prescription steroid ointment here and there for little flare-ups. A rash, when it's an eczema rash, when it's red and scaly in texture, And I usually say to close your eyes and feel the skin. And if it feels sandpapery, it needs prescription treatment. If
Okay.
you're treating inflamed, actively atopic dermatitis skin, you're not going to run into trouble. We run into trouble or side effects when you're treating normal skin. And that could be discoloration, thinning of the skin, or stretch marks. Now, the one caveat to that is we have to be very careful about the type of steroids we put in really delicate skinned areas to begin with. So say the face, the neck, the armpits, and the groin or the diaper area. We do use lower concentrations of steroids in those areas because they're thinner skin and they absorb steroid more quickly. So they're usually quite responsive to even lower strength steroids. But those are areas that we're always very, very mindful of potentially a higher rate of side effects. The rate of side effects when only used on inflamed and actively irritated skin is very, 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 very minimal. And in the hands of the right provider, whether it's your pediatrician or dermatology provider, we work to get you under control with a topical steroid and then usually on a long-term maintenance regimen with a non-steroid topical medication. And there are several out there now that can be quite effective. I do not think they are very effective in the sense of getting the eczema under control, but they can help us keep it under control once we have the rest of the skincare regimen ramped up.
Okay. Now, when you talk about the potential side effects, like you said, skin thinning or stretch marks, I've actually never seen it.
I rarely, rarely see it in children. I feel like the only times I've encountered it are when it's not even necessarily truly the steroid, maybe in a teenage patient that's going through that part of their life where they're already predisposed to developing stretch marks, and maybe they already have some stretch marks, whether it's on the hips, the thighs, or the breasts, and they're also using a topical steroid in that area. They have stretch marks. They're probably from their physiologic growth, but I always get concerned, could the steroids be worsening this? And that's a case, I won't even use steroids on those body parts in that age of patient because of that reason. But I almost, knock on wood, I almost never see these side effects that we're talking about, the skin thinning or discoloration or stretch marks in children.
Thanks for reaffirming that. What about diet? When you see a kid with eczema flares, are there dietary changes that you recommend to a child or not necessarily?
So diet is the absolute last thing I will even consider intervening on, and for several reasons. We know that children with atopic dermatitis may have a greater tendency toward food allergies, but it's usually not that one food allergy is causing their eczema. So for example, it's not that they're going to eat an apple and they're allergic to apples and it causes their eczema. If they ingest a food we know they're allergic to, it can stimulate their immune system because they're having an allergic reaction, and that can cause an eczema flare-up. So they are related, but not directly, not A leads to B.
Okay.
So if a child is tolerating all foods and not having reactions, saying they're not having wheezing, difficulty breathing, immediate hives, or facial or lip swelling related to a food, and they come in with severe eczema, we will work on everything from a skin-directed perspective. And only if we're doing all of the treatments that I have in my wheelhouse and in my toolbox, and the child is really just not improving as expected, then will I have them sent to the allergist for food allergy testing, because maybe they are being exposed to a food they're truly allergic to that's causing this persistent low-level stimulation of their immune system.
Okay.
Otherwise, even if they have a diagnosed food allergy and maybe they get a little eczema, it seems like, when they eat that food, okay, let's control their eczema and let them eat all the foods. I want them to be able to be normal kids and go to a birthday party and not have to ask about what's in X, Y, or Z. That's my goal. I do not want to restrict their diet or their lifestyle unless absolutely necessary and truly for safety reasons. Like they're going to have a true anaphylactic reaction, which can be life-threatening. Of course, we avoid it at that time, but otherwise, no dietary intervention, except I do have one caveat about peanut, if you let me bring that up.
Sure.
So children with moderate or severe eczema, and that has to be diagnosed by your pediatrician or your dermatologist, are at greater risk for food allergies, as I mentioned. What we know about these kids is that we need to expose them to peanut early in life, and all children. When I say early in life, usually between 4 and 6 months of age. And as long as they don't have an allergic reaction to it, we keep exposing them to peanuts so they won't develop an allergic reaction. If we just are probably, and you know better than I do, probably 5-10 years ago, we thought, oh, don't give peanuts. Nope, don't give peanuts, not till they're
Right.
3, and then they won't get allergic. We actually increase the rates of peanut allergy by doing that. So if your child has significant eczema, you need to get in to get evaluated to see how early to initiate peanut. If they have severe eczema, that's one time I will check a peanut allergy blood test before their parents give them peanut. If their peanut allergy blood test says they may be at risk for having a peanut allergy, then I have them do that peanut, the initial introduction of peanut in the office with the allergist in a safe, controlled environment, just to make sure there's not going to be a bad outcome. But otherwise, if their blood test says nope, no allergy to peanut, then we go ahead and give peanut. So that's my one plug for trying to prevent peanut allergy.
No, I thank you for saying that. I think people should hear it over and over again. That early introduction of foods is, especially peanuts, we know prevents future allergies. So thank you. Okay, so just to paint one quick scenario. So let's say, I'm just thinking of what typically comes up in my office. Let's say a child is 9 months old and has strawberries, and they react and get them some eczema around their face, and they get a flare on their cheeks. This child should not then avoid strawberries, correct?
Nope.
Okay.
Nope.
Okay.
And I don't know if you picked strawberries on purpose, but strawberries are what we call a histamine releasing food. So strawberry, the actual substance on the skin, can create almost a hive type eruption just based on the structure of what the strawberry component is made of. It doesn't actually have anything to do with the child's immune system or whether they're allergic or not. This can happen with tomatoes and other citrus products as well. So if they get a little flare up around their mouth that seems more eczema and rashy, put Aquaphor on them before they eat, let them eat all they want, and then gently pat and put some more Aquaphor on afterward. And I like that the Aquaphor pre-meal time for infants and toddlers, because we know whatever there's going in their mouth is going all over their face. That could be irritating. So you lube them up, let them eat, and then lube them up again.
Fantastic. And what about a non-histamine type food? What if it's eggs? Like what if a child, a 9-month-old, eats eggs and gets a rash around the mouth? Same rule apply?
So if it's an immediate rash is going to look more like hives. So red, smooth, raised welts and wheals. That's different. That's concerning for a true allergic reaction. You should not give egg, and you should see your pediatrician before considering introducing egg again. If you notice a couple days later, it seems like their skin is a little more red, dry, or chapped, I'm really not too concerned about that. Moisturize it, continue to give egg, and then work with me or with your pediatrician about a good skincare regimen for the areas that seem to be having some eczema.
That's great. That's great. And just to paint a picture out there for parents that do have children with eczema, how many times a day do you typically see kids needing emollients or Vaseline to the skin, just so they know what they're going to expect?
Yeah. So sometimes it takes a village to treat eczema, especially when it's really severe in the beginning of treatment. And it doesn't always have to be that way, but in the beginning it can be very intensive therapy. So the topical steroids go on twice per day, and the moisturizer or emollient goes on top of it. And then I ask them to moisturize any time during the day when the child seems uncomfortable, dry, or itchy. So it can be up to multiple times per day. For school-age kids, usually before school, after school, and then definitely after bath or shower and before bed. So it can be quite intensive. Usually as we get the skin under control, it becomes much more manageable, and they get in a routine of morning time cream and moisturizer, nighttime cream and moisturizer, and that's a lot more manageable.
And then when can parents expect to see an improvement? Does it take a day, a week? What is your experience?
It depends on the severity of the eczema and how thick those areas of like red scaly eczema patches are.
Yes.
Sometimes they'll notice improvement within 2 to 3 days, and sometimes it'll be a more gradual, steady improvement over about 2 weeks. And it also depends if there's other factors going on, say infection of the skin. If there's also infection and they're using an antibiotic, whether a cream or an oral medication, it will improve a little bit more slowly, because you have to wait for the infection really to get calmed down.
Okay, this is so helpful. And I know you mentioned it earlier, but just so parents can hear it again, the prognosis for eczema is good, right?
Oh my gosh, yes, absolutely. Okay. It will get better. I just can't tell you exactly when and the time frame. And if you get on good, appropriate treatment, we can get it to look, I can't say clear, hopefully completely clear. And then the goal is you have an action plan of knowing what to look for and how to treat it when you get little flare-ups so it never becomes this huge out
Right.
of control fire anymore.
Right.
You might get little smolderings and you know exactly what to do to damp it down so you never get back to that really bad and scary eczema flare again.
This is so helpful. I really appreciate all of
I'm so
your
glad.
words of wisdom on this subject. Is there anything that we're forgetting? Any other last minute tips that you think parents would benefit from hearing?
I think it's important that families also know part of our eczema treatment strategies include controlling itch. So when I think about controlling atopic dermatitis, it's from inflammation, which is red scaly patches on the skin, itch, and infection. So those three I's are what we talk about in clinic a lot. So
Okay.
controlling itch is a huge component of treating atopic dermatitis because the more they scratch, the more the atopic dermatitis will really become present in their skin. So occasionally we do have to use things like antihistamine, say Benadryl, Claritin, Zyrtec, for short intervals to help control that itch response. And I just want families to be open to that idea that I don't give oral medications to children unless I really think they need them. But if I think they need them, it's part of our kind of more intensive treatment process at the beginning of a stepwise therapy where we start the topical treatments and we start the antihistamines and maybe they even need an antibiotic or some other intensive skin directed therapies. Then over time, we peel things back. So it can almost seem a little overwhelming to start doing all these things at one time, but the goal is that we want to see improvement and then we get to slowly take things away, which is great. But unless we treat all three of those eyes at one time, even if we do two of them really well, we can't get it better. We have to target all three components to really get ahead of the eczema.
And just so parents are familiar with the words, what are some typical medications that are recommended for itch?
So for children, the over-the-counter is Benadryl or diphenhydramine. I prefer a prescription oral antihistamine called hydroxyzine or Atarax.
Mm-hmm.
And in the morning, I usually recommend cetirizine, which is the over-the-counter Zyrtec. And those are the most frequent antihistamines we use to help with skin-directed itch.
So thank you so much. This is so helpful. I really appreciate all this advice. As you stated in the beginning, eczema is so common, and it's only getting more and more common. So this is going
Absolutely.
to be very helpful for anyone listening.
Good. I'm so glad. I'm so glad.
Thank you.